So those that don't know, Dr Ramesh Bulusu, consultant oncologist, Adam Brooks Hospital. He's going to give us a research update on the Scandinavian 3 versus 5 year trial on years on imatinib, and an update on the paediatric and wild type clinic. And then he can answer some more questions for you. So I'll pass over to Ramesh.
Right. So the next two presentations I'm going to do very slowly. Try and be almost like old-fashioned horse-driven carriage kind of speed, because I tend to speak very fast. My patients know that. They got used to it now. The GIST journey, so going back to 2002, when I had my first GIST patient, we only had 2. And I thought, oh, life is going to be nice, 2 patients per year. That was fantastic. So we got next to 400 now in the database, in the Cambridge GIST database. And we learned a lot from ourselves, because it's a steep learning curve, and also we learned from the patients as well. Each patient taught us something new, every single patient, all the way through. So if we go back to 2002, we were just happy that GIST was diagnosed. And we were so happy that there was a tablet available, because prior to that I was giving chemotherapy for GIST patients with a response rates of 5%. 5% chance of responding. We put them through 4 to 6 months of chemotherapy, toxic side effects and everything. And then suddenly things changed in 2002, 2003. And imatinib became available for patients with what we call as metastatic GIST, where the tumor already spread. So that was quite successful. And as time went along, people said, oh, wait a minute, can we actually use the same tablet to try and stop the tumor from coming back? That concept has already been there for a number of years, or probably a number of decades, in other cancers. For example, if you take, say, breast cancer, bowel cancer, lung cancer, majority of the patients will have some form of treatment after they have had their primary tumor removed. They may have hormone therapy like tamoxifen in breast cancer. In bowel cancer, they have 3 to 6 months of chemotherapy. In lung cancer, they have about 3 months of chemotherapy. And there's a survival benefit for that, meaning that you live longer if you had the treatment, but the benefit is kind of small. So that concept has already been there. So what has happened in GIST is it took a bit longer to translate that benefit in the metastatic disease into what we call the adjuvant. So that comes to the thing, what is adjuvant? So we use this word quite a lot. We didn't mention the other word to the surgeons. I didn't want to upset them, because it's the first time I met them. There's something called neoadjuvant, meaning new. Neoadjuvant means prior to surgery. That we'll talk about if we got time. So what is adjuvant treatment? You got the primary tumor which has been taken out. Okay, doesn't matter where the primary is. It could be lung, could be GIST. Primary tumor has been taken out. The scans which were done either before the operation or after the operation showed no evidence of any cancer anywhere else, at least from what we can see. We can't pick up microscopic disease. We need to be very clear that scans do not pick up a pinhead sized, contains 1,000 cells or beyond. We can't see them. So pinhead, we can't see it on any scans. PET scans, doesn't matter. We can't see them. So as far as we can see on the scans, there's no obvious disease. So that's the second thing. Likely to be cured. So any patient who has got a primary GIST taken out, likely that they're going to be cured. Okay? And then extra post-operative treatment to reduce the risk of relapse of the cancer, doesn't matter what the cancer is, so stop it from coming back or cut down the risk. If the risk of cancer coming back is 40%, maybe cut down to 30% or 20%, half the risk or quarter the risk. And also try and improve the survival of the patient. Instead of living for, say, 5 years, you live for 8 years or 10 years, that kind of thing. And also you have to look at who's going to benefit from that extra treatment, because most cancers, patients may already been cured by the operation. They may not require any further treatment, but we don't know that. But there's a subset of patients who are at higher risk of cancer coming back. They may benefit from extra treatment. In breast cancer, that could be radiotherapy, hormones, chemo. In GIST, we don't use chemotherapy. We don't use radiotherapy upfront, meaning right at the beginning. But for a subset of patients who are at a significant risk, you can actually work out what that significant risk is. It could be 10% risk, 20% risk, 50%, 80%. You define what that significant risk is, and that group of patients may benefit from the adjuvant treatment, but it's primary tumor taken out. You give something to prevent the disease from coming back. You may not do it 100%, but you try and do that. That's what adjuvant means. So it could be chemo, radiotherapy, immunotherapy, targeted therapy, others, and combination of any of these things. In GIST, we only use that bit. I saw a slide from the surgeon saying chemotherapy. So GIST is not chemotherapy. That's another thing which you need to make very clear to you, your family, your GP, or anybody you see. You're not on chemotherapy. You're on a targeted therapy, which is completely different to the conventional chemotherapy we use for other cancers. So I didn't want to contradict the surgeons again, meeting them for the first time. There were a couple of slides with chemotherapy on them, so this is not chemotherapy. And the adjuvant treatment, the package after the operation, how long you have to be on that, varies from cancer to cancer. So in bowel cancer, the chemotherapy is roughly for 3 to 6 months. In breast cancer, if you take hormone therapies, it could be 5 years, maybe 10 years, 1 tablet once a day. And also you try to work out the risk versus benefit. If it's a very horrible toxic chemotherapy, you can't be on it forever because the body can't handle it. If it's a hormone therapy, you accept some risks. For example, in breast cancer, you say there's hot flushes and then dry skin, joint aches, muscle aches, that kind of thing. You accept that because you think they're going to benefit if you take it for 5 years, 10 years. In GIST, right now, in UK and also rest of the world, the standard of care is 3 years. So you have a high risk GIST removal. We'll come to that in a minute. You have a treatment for 3 years. And that's where you stop the treatment. Not because of the cost, not because of the funding issues. That's what the evidence says. We talked about the risk of tumor coming back. And I said about the 3 things we need to remember: the tumor size, the mitosis. Mitosis are the, under the microscope, the pathologist can tell us how many cells in that field are trying to multiply. You need to go back to your A-level biology, the mitosis. You saw, the mitotic figures? So those things, you need to remember those things. And that's what the pathologist will tell you. And we got rid of the high power field now because each microscope can have a different high power field. So we make it 5 millimeters square. So the Royal College of Pathologists in this country has standardized the whole GIST reporting protocol. So it's a 5 millimeter square, which is slightly different from the high power field. So these 2 guys, Mithran, he's pathologist, Finnish pathologist, went to America, and he went to this pathology center in Washington, D.C. It's called AFIP, Armed Forces Institute of Pathology. It's a army thing, and there's a lot of central funding. Probably got nothing else to do. What he did, he dug up 1,000 gastric GISTs, 600 duodenal GIST, or 600 small bowel GIST, about 100 rectal GIST. How long would it take for me to see 1,000 gastric GIST? 55 years. Okay, how long would it take me to see 111 rectal GIST in my lifetime? I see that would take me 78 years. Okay, so these numbers were actually picked up retrospectively, meaning they went back into the records and dug up the things from a number of years ago, going back 30, 40 years ago. Those days just didn't exist. It was called something else. Back prior to 1983, it was called something else, leiomyoblastoma, that kind of thing. So they dug up the records of those patients and analyzed the tumor size and everything. They come up with a table, simple table. And what they did was size of the tumor, the number of mitoses under the microscope, and where the tumor is. So stomach, first part of the small bowel, duodenum, then the small bowel, and the rectum. And we missed the colon in the middle, large bowel. Large bowel GISTs are extremely rare. Okay, colonic GISTs are extremely, extremely rare. We have seen perhaps, I think, 2 in the last 17 years. And if you got a large bowel GIST, usually it's towards the bottom end of the large bowel where it connects to the back passage, rectum. So sigmoid is the area you see the GISTs, but you don't see in the colon area. Very, very rare. So what they did was they worked out the size of the tumor. You could measure it on the pathology specimen, and you can work out number of mitoses. They just cut off point of 5 or above 5 or below 5. That was a kind of not arbitrary, based on some kind of data, but 5, less than 5 or more than 5 mitoses per so many fields kind of thing. And then divide them into tumor sites where they originated from. And what was very clear was that if you got a small tumor, low mitosis, doesn't matter where you are, risk of relapse is 0. So this patient, a stomach tumor, just 1.5 centimeters, 2 mitoses, you don't have to have any further treatment. Remember, this is based on the tumor specimen which has been taken out, not on a CT scan measurement. These patients have already had the tumors taken out a number of years ago, so they've been followed up until they died kind of thing. So if you got a small GIST tumor, so today if I see a patient with a stomach GIST, they got 1.5 centimeters stomach GIST, I know for certain it's a GIST because I biopsied it from inside, from the endoscopic ultrasound. You can't count the mitosis on a biopsy. You never do that because a biopsy will only give you tiny, tiny, tiny bit of this whole tumor. So we never ever attempt to count the mitosis on a tiny biopsy. However, if I know that it's 1.5 centimeter gastric GIST, I don't have to follow this patient up because the chance of this patient relapsing with that small gastric GIST is very, very low, close to 0. In fact, there are not that many patients were there who had less than 2 centimeters GIST in the stomach and high mitosis. So by default, you can say that if you've got a small stomach GIST, you may not have to have any further follow-up if it's taken out. And you can put it the other way around and say, if it's a small GIST, maybe just watch it. If it's found by chance, for example, what we call as incidentalomas, meaning that they were picked up purely by chance because you were being scanned for something else, and there was a small, tiny thing sitting in the stomach, you could actually watch it. In the rectum, we don't do that. In the back passage, they're much more aggressive. So a rectal GIST, we don't watch them, just take them out. Then you come to this slightly yellowish kind of numbers there, 10%, 16%, 8%. These are low to intermediate risk, meaning that there's a higher chance of relapsing, the tumor coming back. And then in the red are the what we call as a high risk. For example, if you got a 12 centimeter tumor in the stomach or in the duodenum or in the jejunum and you got high mitosis, more than 5, the risk of tumor coming back is very high, almost 100%. So this patient certainly has to have something else. What were we doing back in 2005, 2004? We were just watching them, meaning they were regular scans where there's no treatment available after the operation. We would watch them. If the tumor came back, we used to give them Gleevec, imatinib. That's all we were doing. Now it's different. So this is what you remember from that risk stratification. We don't use the TNM staging for GIST, meaning the other cancers we use tumor node metastases. That's what you see, TNM, because GIST don't go to lymph nodes. Adult GIST don't go to lymph nodes. Very, very, very rare. We only had one patient in the last 17 years who had a lymph node secondary or lymph node spread from a stomach GIST. So we don't take the lymph nodes out when the patient had a stomach operation. We just take the GIST out and that's it. In my practice, I use this bit. I deliberately didn't put the other slides because they're slightly a bit more complex even for me, not underestimating your understanding of the GIST. It's just, there's a guy called Heikki Joensuu who is an oncologist from Finland. He produced some prognostic contour maps. What I mean by that is, if you imagine you got a small bowel GIST there, let's put it this, okay. Where do we put it? Okay, 11 centimeters GIST. Yep, 11 centimeters stomach GIST. 11 centimeters stomach GIST, 4 mitosis. Okay, What's the risk of relapsing? 10%. 11 centimeter GIST, 6 mitoses. You jump from 10% to 86% by just changing the mitosis from 4 to 6. Really? Is that true? But that's what the table says. So what the Yohunsu guy did was that actually he constructed some kind of a map for each mitosis, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So what we call as a continuous variable, not cutting the people into two halves, the patients into two halves, less than 5, more than 5. 1, 2, 3, 4, 5, 6, all the way through. And that gives you a different perspective on the risk of tumor coming back. And what I do now is also at the mutational analysis. That means what is driving this tumor. We talked about the train with the compartments and the seats, where the driver is sitting. The driver is the mutation. Where is the mutation? Is it in the front of the train, back of the train? Which seat is the mutation, in which compartment? That gives me extra information. And I had this live yesterday, in my day before yesterday, in the clinic. Patient referred for a second opinion for adjuvant treatment. Small bowel GIST taken out, 7 centimeters, 2 mitoses. So 7 centimeters, 2 mitoses, his risk of relapse is 24% according to this. And then we use this data and the Yohunsu's the contouring maps data, and we worked out that his risk of relapse is about 10 to 15%, not more than 20% at the most. And I had a frank discussion with him and his wife. Sit down, what do you want to do? This is the data. Are you comfortable not having imatinib, or are you anxious that you should have imatinib? And he said, no, I'll take my chances. 80%, 85% chance of not coming back, I'll take it. Whereas he was uncomfortable with the 24% chance of relapse. So that 5-10% made a difference for him psychologically, that he would be prepared to accept 1 in 7 chance of tumor coming back in the next 5 to 10 years, rather than 1 in 4 chance. So end of the consultation, took an hour and a half, but end of the consultation, we 3 were happy. We said we'll go to the pub. No, we didn't end the pub, but we did think of going to the pub. But we sent him back to Norwich. So he came from Norwich, we sent him back to Norwich. So I don't use this on its own anymore. I use this as my basis to start with. If you're in this category, you don't have any further information, you know that high risk, you automatically have imatinib. What is mandatory before you start the adjuvant treatment is you have to have the mutational analysis done. Why is that? In stomach GISTs, some tumors have a resistant mutation to imatinib. That means putting them through 3 years of imatinib cost about 50-60 grand, and also for no benefit. So we don't use imatinib in that group of patients, which is the one Jane was talking about earlier, D842V mutation, which does not respond to imatinib. So if you know that that patient has got that mutation, you will not give them 3 years of Gleevec imatinib. And then patients with wild type GIST, meaning patients who do not have any mutations in those 2 genes we talked about, they do not benefit from this treatment. And also this table does not apply to them. This table is primarily for patients with KIT and PDGFRA mutations. This table does not apply to the young pediatric adolescent wild type syndromic GIST patients. And so we don't give any adjuvant treatment for them. So what's the evidence we have so far is this. This is the American trial, compared 1 year of tablets versus placebo, and they were just said any GIST more than 3 centimeters or more, and they showed that there's a benefit on the relapse-free survival, but no difference in the overall survival. So, but that became a standard of care in America. Everybody in America who had a GIST which is more than 3 centimeters got a tablet for 1 year. But we knew that majority of them did not need the tablets, because looking at the table, the risk of relapse would have been low. Then the EORTC, which is the European and UK consortium, did same tablet, imatinib 400 milligrams once daily for 2 years versus observation. They didn't give a placebo, just observe the patient. And what it showed is that there's a slight benefit if you give 2 years. But again, they included patients who may not have benefited from the tablets. So what we call as the intermediate risk. So the benefit was there, but it was very modest benefit for giving 2 years. And this is the trial which changed the practice. This trial is called SSG, Scandinavian sarcoma group, trial 18, joined with the Germans. And what Heikki Johansson, who is the chief investigator for the trial, what he did was that he said, I'm not going to give the tablets to everybody. Somebody's got a 3 centimeter gastric GIST, stomach GIST, 2 mitoses, they're not going to relapse. The relapse is 1.8%. What's the point in giving them 3 years of tablets? Pick up the high risk group, the ones who are in the red. Give them the tablets and don't ask the question whether they benefit or not. Ask the question how long they need it for. So 1 versus 3 years. So he made a big jump in the assumption that these high risk patients are likely to benefit from tablets after the operation. And the randomization was between 1 year versus 5 years. So 1 versus 3 years. So half the patients had 1 year, half the patients had 3 years of tablets, and they followed them up. And if you look at these tumors, more than 10 centimeters, any rupture, high mitosis, more than 10 mitoses, or size more than 5 centimeters in the small bowel, mitotic rate more than 5. And there was a difference in the survival. If you take the tablets for 3 years compared to 1 year, you're more likely not to relapse. 71% chance of not relapsing compared to 52%. And if you look at the survival, you got a 7% better chance of surviving if you take the tablets for 3 years compared to not taking the tablet, only taking tablets for 1 year. And this was taken up by the NICE a couple of years later. And what they said is imatinib is recommended as an option for adjuvant treatment, meaning after the primary tumor has been removed, for up to 3 years for adults who are at high risk of relapse after surgery, for KIT positive tumors as defined by the Meaton 2006 criteria, the one we saw, the table we saw, the ones in the red. What this leaves you is you have to define for yourself what do you accept as a high risk. Meaning, what is the cutoff point? Is it 10%, 16%, 24%? So we know for certain, the red ones, we don't have any concerns, we automatically give them. But what about 24%, what about 10%, what about 16%? Are they high enough? Does the patient and the family, do they feel that that's a high risk? Then we discuss. But the NICE and rest of the regulatory authorities, they actually left it open for us to make the decision. They didn't put any mandatory cutoff figure, what you can have, when you can have it. But the standard treatment is up to 3 years. It's not a funding issue. It's purely based on the scientific data on the clinical trial that 3 years is better than 1 year. That's the only reason why 3 years has become standard of care. And Americans do something very different. Can I say that live? Maybe. They just sometimes give without any, for 4 years, 5 years, sometimes 6 years. The French are doing a trial comparing 3 years versus 6 years on their own. We don't know why they joined us. They probably want to be different. So what we have here is we have the this 3 versus 5 years trial. Heikki Johansson is the chief investigator for the whole trial. I'm the CI for UK. So the question we're asking is, giving extra 2 years of the tablets after the operation, would it make a difference? Would it benefit the patient? Patients with a high risk of relapse. So we're not taking those patients with 2 centimeter tumors or 4 centimeter tumors. We're taking the patients with big tumors, high mitoses, or the tumor is ruptured. So these are the ones we are taking. So if we go to the slide where we have that. So we got a funding from Cancer Research UK to run the trial in UK. So we got nearly close to £500,000. And SSG, which is Scandinavian Sarcoma Group, are the sponsors. And we are the co-sponsors in UK. We are the legal sponsors. And so who are these people who are likely to benefit? This is a survival curve. This is the time period. These are the percentage of patients who are relapse free. They're still alive, they haven't got the tumor coming back. So this is 1 year imatinib. This is 3 years. They had the operation somewhere there. They do not have metastatic disease, meaning no secondaries. They had 1 year versus 3 years. You can see that patients at 3 years imatinib, they're doing better than the 1 year imatinib. But You stop the imatinib, they are relapsing. When do they relapse? Not on day 1, about, you look at this, 1 year after the operation. And that has implications on how you follow up. Somebody was asking me a question, what happens to me when I stop the 3 years of imatinib? And I have a different approach compared to other oncologists in the country. So for example, I don't really scan people when they're on tablets that much. Say in the first 3 years, I don't scan them. Especially if I know a mutation is very sensitive to imatinib, that's where the mutational analysis is quite critical in the adjuvant setting. If you've got a very imatinib sensitive mutation and they are here, they may get 1 scan, maybe 2 scans in the 3 years, not many. Once they come off, I scan them more frequently. I scan them every 3 months, every 4 months, because I know that they've got higher risk of relapsing when they come off the tablets. So I want to pick up the relapse as soon as I can, not waiting for 2 years for it to relapse in big tumor. So this is the difference between the practice we used to do. People say, oh, I've done 3 years, I'm free now. But in fact, the risk starts about 1 year after you stop the tablets. And I keep them in this shaded area. I actually scan them much more frequently. And also I use my mutational analysis data, meaning the information we have from the tumor, to try and predict what would happen to the patient in year 5, year 6, year 7, year 8. So we started implementing that in Cambridge already. So I have this discussion with the patient, try and explain that in very simple, kind of a non-technical terms. It takes maybe half an hour, 40 minutes to explain that. That's what's spending right at the beginning, so that they understand why suddenly we increase the scan frequency in year 4, year 5, when they say, I'm fine. So you're fine, good, but the but is there's a higher risk of relapse. So that's what I'm doing now. So this is the group of patients. This is the group of patients who may benefit from extra 2 years. If you give them year 3 to 4, 4 to 5, you may make the curve flatter and hopefully cure more number of patients. That's the adjuvant trial. So all patients get 3 years. So they're not in the trial. All the patients' standard of care is 3 years. At the end of 3 years, if they want to take part in the trial, we randomize them, either get 2 years extra or we just follow them up, because that's standard of care, that's normal practice. So we follow them up or they get 2 years. So that's the scheme of the trial, and aim is to try and predict what would happen to these patients with regards to the relapse-free survival, meaning tumor not coming back, and also trying the overall survival as well. Right. So who are these high-risk patients? Stomach GIST, mitotic count more than 10, or non-stomach GIST, meaning small bowel, colon, rectum, more than 5 mitoses, irrespective of the size, or if you got a non-stomach GIST more than 10 centimeters, but patients had preoperative imatinib, or if the tumor is ruptured, meaning it's spilled into the peritoneal cavity, either before the operation or during the operation. That's considered as a high-risk factor. So those patients are randomized into either observation, it's a toss of coin basically, 50-50, chance that you may go into that arm or this arm. And the ones which we exclude are that one there, D842V mutation. We don't want them because they do not respond to imatinib. What's the point in giving them 3 years, 5 years kind of thing? And where do they happen? They occur in the stomach, exclusively in the stomach. So for example, you've got a small bowel GIST, it's unheard of you having that mutation in your GIST. So that GIST happens exclusively in the stomach, and that is resistant to imatinib. And this does not apply to us, this more than 800 milligrams, because we're not allowed to give more than 800 anyway in this country. And in fact, there's a problem about giving 800 as well. And also, if you got a lot of imatinib prior to operation, you're not eligible as well. And then there's concern about HIV and hepatitis B, because there's some data coming through from the hematology patients, blood cancer patients, that there may be reactivation of these if you're on longer term imatinib. So these patients are excluded. Briefly, I'm going to touch on the neoadjuvant imatinib. What does it mean? Meaning giving tablets, imatinib tablets, prior to an operation to shrink the tumor. we don't do it routinely in every single patient. We talked about one of the operations where the stomach has to be removed along with the spleen, pancreas, that kind of thing. So we try and avoid that. We do not like multi-organ resections in GIST patients. So if you got a big GIST sitting there and the surgeon says, I can take it out, but I'll have to sacrifice the whole stomach, the spleen, pancreas, and the part of the colon, we say, wait a minute, can we treat him with tablets first, shrink the tumor, and then you can do a more conservative operation. And we do that fairly regularly now in Cambridge. So if you've got a big GIST, biopsy through endoscopic ultrasound, confirm this GIST, number one. Number two, do the mutational analysis, confirm that the tumor has got a imatinib sensitive mutation in KIT exon 11 or PDGFR alpha. And then if the surgeon says, I can operate on this one, but it requires multi-organ resection, you give them imatinib for X number of months. X number of months would be 6 to 12 months. Do regular scans, tumor shrinks, and then you operate at a later date. The advantage with that is first you reduce the blood supply to the tumor becomes less vascular, meaning, remember the pictures we saw with the surgeon, the really horrible looking pictures, they become very, very dry and they don't bleed anymore. And second is, you're likely to do a more conservative operation, meaning that you preserve the stomach, hopefully don't take the pancreas out, hopefully don't take the spleen out. Sometimes you may end up doing that, but there's a chance that you may actually do a more conservative, less risky operation. So that is what neoadjuvant imatinib means. To have the neoadjuvant imatinib, you should have the mutational analysis data. There's no exception to that. Same thing with the adjuvant imatinib. If you're going to have imatinib tablets after the operation, you should have the mutational analysis data. That's mandatory. So the trial was open back in 2017. It's been a challenge because doing trials in rare cancers is very, very difficult. Trying to find the patients is very difficult because of all the inclusion-exclusion criteria. As it is, GIST is a rare cancer. That's the first thing. And second is, you're actually putting constraints on who can go into the trial, and you cannot go into the trial. And that means you're taking half the people out of the trial population. So then you say, oh, I'm going to have 300 patients. Where are they? I can't find them. So we struggled. So what happened? So we opened in 2017, 8 centers in UK. So first activated in January 2017. So nearly 2 years, 17, 18, 19, coming up to 3 years. And we had a target of 20 patients per year in the whole of UK. We thought we could hit that, but we struggled because it's difficult to find these high-risk patients. And also, we didn't open the trial in every single center for logistic constraints, partnered with the funding of the trial as well. Because every time you open a trial, there's a big setup required in the trial center. If you only got 1 patient per year, it doesn't make sense for them to open the trial for 1 patient. And so we picked 8 centers, which got the high volume GIST patients. And we only got 23 so far. Our target for the second year, which is in March, which is not very far away, is 40. We got 1 more patient last week, so we got 24. So we are actually behind. This is the projected accrual rate for the trial. We are actually a bit behind, about 3 months behind. And it's not just us, elsewhere as well. The target is 300. Globally, we only got 135. We've got more than half to go in the next 1.5 years. And what has changed a bit more optimistic is, these are centers from 1, 2, 3, 4, 5, 6, 7, 8, 9 countries. Spain are doing very well. I don't know where they find the patients, but they're doing very well. We're second highest. We're beating everybody else, including Germans. Having said that, Germany they're fantastic for trials in Germany. They're very well coordinated, and they run trials with super efficiency. So they joined only about 6 months ago. They only got 14 patients. So very likely that they will actually overtake us. And we hope to complete this trial recruitment in 2021. And that will take another 3-4 years for the data to mature, and you won't have any data for another 2025, 26. So the question we're asking, simple question is, if we give extra 2 years after 3 years for that high risk patients, would it help the patient survive longer? That's the question. So that is something which we need to think about. So we have to thank GIST Support UK, because GIST Support UK is providing us with the travel reimbursement for patients who can't get to the center where the trial is. So there's a patient for me who's coming from Norwich, who the trial is not open in Norwich, but he's willing to travel. So he takes the bus or sometimes takes the car, comes to see me, and we put him in the trial. And GIST Support UK is reimbursing the trial. And also GIST Support UK has kindly funded the trial extension along with the money we got from the Scandinavian Sarcoma group. So we are very grateful and thankful for that. The reason why it is important is this question needs to be answered, because people say, why bother? 3 years, I'm happy. But there are that subset of patients who are likely to benefit or may benefit. Oh, hello. May benefit from the extra 2 years. That extra 2 years might be worthwhile for that group of patients. And if we know that information in, say, in 3 to 5 years' time, that will become standard of care. And then also we can tell to other patients that actually you don't need that extra 2 years, because you're just actually, you can handle with 3 years, and that should be fine as well. So that's a very important question to answer. Otherwise, we would never know what the optimal duration is. 3 years we think is adequate for most of the patients. I think 3 years should be adequate for most of the patients. But there are one small group of patients who may benefit from the extra 2 years. The only way you can answer the question is by doing the randomized trial. Otherwise, it will be biased. If you just pick up the patient, oh, I want to give you 5 years, I want to give 4 years, you will never get the answer because it's not randomized. So you avoid the bias kind of thing. So that's where we are with the trial. And I'm going to stop there. If you want me to questions now or whether, yeah, okay.
Can I have a question?
Yeah.
What could we do to help you with recruitment in the UK?
Right. So it's two-part answer to that. One is.
Can't do that. It's on the computer.
What's that?
Sorry, he's asking for the agenda, but it's on there and it's not connected.
Right. It's advertise and try and on the list of if patients are actually saying I'm on Gleevec for 18 months, my operation was so and so, ask them to refer to the nearest centre. So we got in this area, Manchester, Nottingham, Birmingham are the 3 centres, and up north is Glasgow, and then down south it's Marsden, UCLH, that's London, and Cambridge, and then there's Sheffield in the middle somewhere. So we got 8 centres. So if you are on tablets after your operation and if you fulfill the criteria, you should ask your oncologist, what is the risk status for my tumour? How many mitosis, what is the size of the tumour? Look at the table, where am I in that table? Is there on the yellow or red? And would I be eligible for the trial? And then you say, could you refer me to this centre, which is my nearest centre? So that's how you can actually help to increase the trial recruitment. We have been engaging with the oncologists, trying to make sure that they have a database set up and then they know who these patients are, because we would know who's taking imatinib from the pharmacy prescription. What we can't tell is, are they taking the imatinib for metastatic disease or are they taking imatinib for after the operation adjuvant setting. So we don't know who they are, but we would know who's taking imatinib, and the oncologist would know for what reason they're taking the imatinib. So we're trying to educate the oncologists as well to try and get them to recruit more patients.
Okay.
But it's a global problem for rare cancers. It's a very challenging problem in the rare cancers.
If anyone doesn't have any other questions, we have to move on to the other presentation fairly swiftly, or we're going to run out of time. We can do some more questions. Oh, sorry, Karen. Yeah. If you get the other one up, at least.
Yeah.
So my question was, it seems when you were showing how your approach to following patients up after they've finished the imatinib and you start to observe them more frequently after they finish, I was just wondering in this trial whether you were looking at any sort of predictive
Yes, we are.
markers that might...
Well, yeah,
might identify the
we're
patients
doing,
more likely
yeah,
to-
exactly. We're doing biomarkers, blood markers, and also tumor markers to get extra information. What else can we use information-wise to predict what would happen to the patient? Because at the moment we got this mitosis and all these things, which we think are not crude but a bit basic. So we're trying to work out whether any other markers within the tumor sample or any blood markers would help us to tell us how often we have to follow the patient. So that's this part of the trial. But waiting for that in real life, I changed my practice in the last 2-3 years after having seen the data from 1 versus 3 years. So anybody who's coming up to 3 years now, I definitely scan them more frequently from year 4 onwards, and year 4, year 5, and up to year 6. And then the survival curve becomes flatter, meaning that they're no longer relapsing. Then I back off a bit. And I explained to this patient, to actually, in my clinic, I show the survival curves, the hazard ratios, but explain in a simple way what it means in plain English, not the gobbledygook scientific languages. You need to explain that because it's completely different to what it's counterintuitive that you actually start scanning people when they're supposed to be in remission 2 years ago. You say, I'm fine. I mean, I'm 6 years down the line. Why should I bother about scans? But your risk actually starts in end of year 4, so you should be scanning more often. I don't scan.
Scans, which type of scans?
It's a
do you
CT.
recommend?
It's a CT. CT is still the standard of care. Oxford, they do PET scans on all their patients. I'm a bit worried about that in the sense that PET scans, that's the way they do it. But in the guidelines, when we written the guidelines in 2004, 2009, 2017, we said CT is the standard of care imaging-wise, except one area, which is the rectal gist. Gist of the rectum, MRI. So that those patients get MRI. But rest of the body, it's CT. And has to be reviewed and interpreted by a GIST specialist radiologist, not a sarcoma radiologist. There's no sarcoma guys here, right? Okay. In a sense, I'm not a sarcoma surgeon. I'm not a sarcoma oncologist. I'm a GIST oncologist. So there's a big difference between sarcoma and GIST. Though GIST is part of the sarcoma, GIST is primarily a GI tumor, meaning it's a gastrointestinal tumor, because it occurs in the digestive tract. All the imaging, all the surgical principles, that is why you have a GI surgeon talking to you about the GIST operations, not a sarcoma surgeon who talks about bone operations and that kind of thing. That's another reason why we have to be careful. So GIST scans should be reviewed by GIST specialist radiologist. We talked about the size of the tumor. Sometimes tumors get bigger while you're actually giving them Gleevec, but that's not a sign of progression. It's a sign of response because the density has gone down. They become like cystic, like a balloon. They bulge. And if you don't realize that, you stop the treatment because the radiologist will report this tumor has gone up by from 10 centimeters to 14 centimeters. That's 40% increase. You stop the treatment, but that's a sign of response. So you need to get those things as well.
Yeah, Ramesh, if you come down dramatically after 4 years, do you automatically put your patient straight back on?
Right. What would happen if a patient is on 3 years of tablets and the tumors come back? Say 6 months later, 1 year later.
When you scan them?
Yeah, when you scan them. In my practice, I actually biopsy. I biopsy the patient again. If, say, for example, they got a small bowel just taken out 4 years ago, and they stopped the tablets 1 year ago, and they're now on regular follow-up. CT scan shows a lesion in the liver, a secondary in the liver. I don't presume that it's a GIST secondary. I put a needle into that, try and confirm that I'm definitely dealing with a GIST secondary, because one of the concerns we have is that 1 in 7 GIST patients they can develop another cancer because they're in the same age group as anybody else. Prostate, lung, breast, bowel, common cancers. So you can get a common cancer, not because of GIST, but you can get a common cancer because in the same age group as anybody else walking down the street. So the biopsy the lesion confirms definitely GIST, and also double check that it's the same mutation, what they had before, and they put them back on Gleevec. They put them back on imatinib, and they stay on imatinib as long as they keep responding. There's no time limit for that.
So they could be on for another 10 years?
Whatever. As long as they keep responding, they keep taking the tablets. As long as there's no side effects from the Gleevec, they keep taking the tablets.
But if they don't come down dramatically, you don't give them imatinib for how long?
You just follow them up. Yeah, say for example, you finish 3 years of imatinib, and then you check them regularly, and they're 5 years down the line, that means 8 years from their diagnosis, and thing has not come back, you back off. you back off. You don't scan them that often, you probably see once a year, because we know that survival curves. Having said that, I may be saying completely opposite to this today in 3 years' time, saying that you have to scan them at 8 years as well, because that data is not there yet. Because we have not got the long-term follow-up of those groups.
Does that mean that the cancer's not growing anymore then?
No, we can't see them. We can't see the cancer. So that's what it means. When you say CT scans are normal, we can't see anything. We can't see microscopic disease. The expectations and the hope is that the imatinib we have taken for 3 years has killed off the microscopic cells. And the highest risk of relapse is after the operation is in the first 3 years. If you're not taking Gleevec, for example, it's the first 3 years, the high risk. Then you go to intermediate risk and then low risk. When you come to 7 or 8 years, we back off a bit. As the surgeon was saying, you can actually have a relapse 20 years later, but who can predict what's going to happen in 20 years' time? So we have a trade-off between how long we follow the patients up. So usually we say 5 years, and then have a discussion with the patient, how they feel psychologically coming off the follow-up, or they want once-a-year scans, perhaps, or telephone consultation. Are you fine? Okay. Any symptoms? That's individualized.
Right. Sorry to interrupt. Is this on?
Yes.
You can hear me. Good. Right. Ramesh is going to give us a quick update on the PAWS-GIST clinic.
So, as you know, we started the clinic back in 2014. 17 clinics?
Yeah, I think
Yep,
so.
17 clinics. And it's been, you're going to see some terrible pictures now. There you go.
Oh, yeah, this one's in the
Yeah,
middle.
there's some pretty ones as well. Each one of them have contributed to the clinic in their own specialty. And there's a geezer here, I don't know who it is, but Robin Jones, Charlotte Benson, Olivier Geiger is a pathologist, Philippe is a pathologist. One additional, Ruth Case is an endocrinologist. She's not a cancer specialist. She deals with endocrine disorders like diabetes, thyroid, that kind of thing. But her passion is STH deficient GIST. So she's very much into this. And the other person is Professor Eamon Maher from Cambridge. He is the genetics person. He's done a hell of a lot of work with our clinic. And Hardwick is a surgeon, and nobody would ever mention anything about GIST without mentioning Ian Judson, Professor Judson, who's now retired. He's still in New Zealand, is he? Yeah, he's enjoying his life in New Zealand. He's doing a locum and then enjoying life there. And then Mike Lee from Manchester, and then Palmadelio from UCLH, Nick Carroll from Cambridge is my GIST radiologist. So we're close to 100 patients. What is striking is in the adult GIST patients is 1:1, male to female ratio, approximately 1:1. Here's much more female than men. And as we heard earlier, same kind of a symptoms, anemia. But what is striking is the young girls, they actually have a hemoglobin sometimes of 440, 50. They seem to tolerate it for longer than the adults. About a quarter of them actually had secondaries at the time of diagnosis, and nearly half of them actually had secondaries when they came to the clinic. What is very, very different is, if you look at all PAWS-GIST patients came to the clinic, and the big spike seems to be 20 to maybe 60, that kind of age group. But just look at the STH deficient GIST. It shifts this way. They're much younger. We only had none in the 60 to 70. We only had one patient, I think, or two patients in that age group. So it's extremely rare as you get older. And the curve actually shifts more towards the younger population. So if you look at the 11 to 20, 21 to 30 seems to be the biggest chunk, and 31 to 40. So these are all comers. This includes not STH deficient, other GIST as well. So what do you mean by these things? And the GIST location, mostly stomach. Big chunk of, nearly half of them actually got stomach GIST. Some of them have multiple GISTs in the same organ or different organs. So the subtypes of PAWS-GIST, the biggest chunk is the STH deficient, succinate dehydrogenase deficient. And then we have this syndrome called neurofibromatosis, where they get freckles and we get lumps on the skin and everything, neurofibromas, and they also get GISTs. And they're a bit challenging to treat. So they are that 13%. And the nearly about 20%, we don't know what is driving. We don't know the driver. Where is he sitting? She, he, it. Where is the driver sitting? Which compartment? Is it KIT? Something else? We know that it's not KIT. We know that it's not PDGF alpha. We know that it's not BRAF. What is driving this? So we don't know what is the train which is driving this tumor. And that's again holy grail to try and find out. And now we got some evidence that some of those just could be due to some other gene abnormality called NTRK. And there's another called FGFR, that may be another gene. These are tiny, tiny proportions they're talking about, less than 1% of the PAWS-GIST. So very, very small proportion of patients. And then we also found out that some patients actually have more common GIST. They come to the clinic as wild type, but they've been misnamed or misdiagnosed as wild type. And we went back and looked at it, and they actually had a mutation in the KIT gene. So they're no longer wild type, they got a KIT mutation. So 80% had primary GIST taken out. This is a striking figure in the PAWS-GIST population. Nearly a third of them actually had emergency operations, which we rarely see in the adult population. In the adult population, the percentage of patients having emergency operations is 10%. So it's 3 times more common in the pediatric adolescent wild type, often because they actually tolerate the symptoms much longer than the adult population, and suddenly they come with a massive bleed and they have to have an emergency operation. And patients had at least one tablet treatment. Problem with that is a lot of these tablets may not work very well. One patient had selective internal radiotherapy for liver secondaries, which is a specialized form of treatment which is primarily designed for bowel cancer metastases, bowel cancer spreading to the liver. And this patient was treated in Liverpool, is presently in complete remission. One patient. Second patient is going to Liverpool again. We linked up with the Liverpool team because they got more experience and they got the funding as well. That's another reason. And we don't know what the long-term outcome of these patients is going to be, because all the data come from bowel cancer patients, so we don't know the long-term outcomes. We are very cautious going down this route. And 2 patients had, we were talking about the blocking of the blood supply to the tumor. We've done that with 2 patients and it seems to have worked, stopped the tumor from growing. So there's one tumor growing out of say 5 or 6, and one thing is causing problems. If it satisfies the criteria, meaning that the blood vessel is there supplying the tumor, it's not supplying the rest of the, say for example stomach or something, you can actually selectively block it. And we've done that with 2 patients. And 3 patients entered clinical trials. The problem is we don't have any clinical trials right now which are GIST specific. So that's the problem. So what we've done so far, so tissue bank established. Ruth Casey, the endocrinologist, she's completed the study, and we have not seen any signal there. What I mean by that is the study was negative. It's not useful for wild type GIST patients. Henri Dabitz, he's in Glasgow. He's actually working on the STH deficient GIST. I'm meeting him next week. So he's going to update us on what his research was. And then Olivier Giger from our lab, he has done some work on the hypermethylation part of it. And clinical trials is the big question mark. And this is no uptake of gallium. This is Henri's data, just ignore that. This is Olivier's data. We changed the way we look at this for now, because any stomach GIST, for example, younger than 50, we're now doing this special staining for this protein called SDHB, and then we take them out, because if it's negative, we go down this route. If it's positive, meaning that the SDHB is preserved, we go down this route. So this is a completely different way of looking at how you stratify GISTs. We presented the data in Rome last year, 2018 November. That was the PAWS-GIST data. And then we subset of the PAWS-GIST with the neurofibromatosis data we presented in ASCO this year. This is the second largest series in the world. So what next? So data and tissue collection is ongoing, clinical studies desperately needed, very slow progress, and we said we collaborate. So we did start the collaboration with Americans last year. This is the consortium Americans and ourselves, and the couple of rest of the world guys as well. And this is a very peculiar tumor, very unusual tumor, very rare, 1 per million. And I'm going to skip this primarily because we'll be here for the rest of the evening and it'll be dozed off. Okay, so there's a trial going on in America using this drug called gordocytabine, which is a methylation inhibitor, and trial opened in 2017. The results are likely 2020. There's no signal as yet, but there may be reason for that. This is the trial we're hoping to open here in this country. It's just been opened in America, and the protocol has been sent across to us. This is a chemotherapy drug primarily used for brain tumors. So remember, we never used chemotherapy in GIST patients in our life, so just need to be careful. But there's a rationale for this, so we think that this may be a good idea only for the SDH deficient GIST patients, not for the NF1. These are the two things I talked about. This is the new gene called TRK or NTRK, which fuses with another gene and becomes the driver for the tumor. And this is extremely rare. And we're going to NICE end of this year, aren't we?
Yeah, there are appraisals of 2 drugs which are particularly NTRK fusion inhibitors. Obviously, they're not licensed yet, but we're hoping they might be, because they're what they call tumor agnostic drugs. So any cancer that is caused by these NTRK fusions potentially would benefit from the drugs that are designed to tackle that and to inhibit it.
So what we're doing now in 2019 and beyond is we're going away from tumor-specific treatments. For example, breast cancer drug, bowel cancer drug. We're going this way, that you find a target in a tumor, doesn't matter what kind of tumor it is. It could be lung cancer, it could be bowel cancer, because same gene is also seen in lung cancer patients as well. So it's a driver in lung cancer as well, but tiny proportion of lung cancer patients. So if you find a gene in any cancer, this is the driver, you have a drug for it.
But in GIST at the moment, which group of GISTs are most likely to have that fusion?
Most likely would be what we call the quadruple negative, meaning where we didn't find a driver. What's 21% of the wild type GIST patients. That's where we're going to find it, I think, because what we know so far is that STH deficient GIST patients, we've tested about 4 so far. They come back as negative. I looked at the database. We tested 6 in total in Cambridge. All of them are negative, including 4 STH deficient GIST. So we don't think STH deficient GIST will have this fusion protein. It's going to be that group of patients where you have not found a driver. And last slide. Right. This wouldn't have happened without GIST Support UK and Jane and Judith, Nick, everybody else in the GIST Support UK, because without their active participation and driving this, because we've been sitting there scratching our heads what to do, and this idea came along from GIST Support UK back in 2011. So I went to the NIH clinic in America, found out how they were doing things, and we tried to adopt that model to us and found the right people to join the consortium. And then the researchers, this is where we're lacking a bit, engaging with the pharma. And aim is to find successful treatments. And I just said to myself, we'll get there. I said, promise to myself, we'll get there. I didn't put promise on that one because I didn't want to jinx it. So we'll get there. Thank you.